I really want to thank the PANC for affording us this opportunity to come back and do this panel again with you this year. I think it was a wonderful success last year. We had a lot of fun doing it. And this year, we really wanted to sort of reprise this panel, although we have some members on the panel that are different this year than last year, so that way we can sort of exercise the theme that we're going to, the theme which is non-motor symptoms of Parkinson's disease. So, like Nancy said, my name is Suketu Khandhar. I'm a movement disorder specialist at Kaiser Permanente in Sacramento. A lot of familiar faces in the audience today. I had my mentor tell me when I first gave a talk at UCSF to a patient panel, I started cracking a few jokes, but everyone was, of course, very stoic because of their Parkinson's disease. And I had no idea whether they appreciated what I said or not. So I know a little better now. I certainly wanted to thank Nick for talking about caffeine because, of course, there was a rush for caffeine right after during the break. But like Nick, I also drink a lot of coffee as well. But surprisingly, I actually never drank coffee when I was in college, med school, or even in my residency. It wasn't until I had kids that I actually started drinking a lot of coffee. And on that note, it wasn't until I had a daughter that I started developing white hair. So for those of you who have known me for about 10 years, you've seen that color change. Nick, on the other hand, he had a full head of hair, actually, before he had kids, and now look at him. So it's my pleasure to introduce this panel, but before we do so, a few ground rules. So number one, this is really not the forum to discuss anybody's individual medication regimen or individual care. We're really going to use this as an opportunity to talk about non-motor symptoms particularly. Dr. Thacker really helped us segue that with the last few of his slides where he talked about symptoms such as constipation and orthostatic hypotension. This is what we're going to use during the panel. This is sort of what we want to leverage from the expertise of this panel. Second thing is that we are going to try to get to everyone's questions. Now, in previous years, we always had people coming up and asking questions. We thought what actually worked well last year was people write down their questions on those 3x5 cards that are in your packet. And during this first half of the forum, I want you to go ahead and write down questions. During the lunch break, we will organize and categorize those questions, many of which, of course, will be similar. And then I'll go ahead and introduce those questions to the panel in the second half. We will, of course, I have a few pre-formed questions that I'll be asking to the panel before we break for lunch, and many of those questions that you guys may have may be answered simply just by that. But as we go along with this first hour, whatever questions you guys might have that is non-motor related, please jot those down and bring them up to us during the lunch break. So without further ado, I'd like to first introduce our set of gals here towards the right. Erin, Vestal, and Christine Shade are two neuro-PTs that work with me at Kaiser Permanente. They both are housed up in Roseville. So what is a neuro-PT? So about 80 to 90% of all physical therapists who graduate from therapy school are orthopedically trained. They're wonderful for that hip replacement, that knee surgery, that back surgery. But neuro-PTs take it a step further. They understand neurological disease. They understand degenerative conditions. And these gals are actually amongst the best. So they're not only trained in trying to treat all aspects of neurology, they're specific for Parkinson's disease. And there are multiple modalities when it comes to physical therapy, sort of modalities to treat Parkinson's. So without further ado, I'd like to introduce them to give them a few minutes, to give you all a few minute spiel about what they do and certain pearls that you guys can take home with you.
Well, good morning, everybody. This is really impressive, I have to first say. My name is Erin Vestal. As Dr. Khandhar told you, I'm a neurophysical therapist at Kaiser. This is my colleague, Christine Shade, also a neurologic physical therapist at Kaiser, and we work in Roseville. So do we have the slideshow on this? From the physical therapy perspective, a lot of people expect that we do a lot of movement, which we certainly do, but as it pertains to Parkinson's, we know there are non-motor symptoms. Dr. Thacker brought a few of those up that can affect all of you. So in regards to physical therapy, some of the ones that you may not realize that we may be able to assist with are going to be some issues around constipation, sleep disturbances, also mood, so depression and anxiety, not to mention cognition and slowed thinking or limited ability to dual task. Sorry guys, the slides aren't maxing up. Go ahead and go to the next one. So as you can see there, and then let's go ahead and move to our next slide. Oh, that's right, I have a clicker. Sorry, guys. No, you do it. No, I'll do it. Okay. Here we go. So one thing we wanted to bring up as it pertains to physical therapy is that a lot of patients or their caregivers may come to therapy and they tell us, hey, we know we're supposed to exercise, but darn it, I cannot get my loved one to do it. I'm struggling to get them interested or consistent. And so we wanted to focus this first piece on that apathy. About 17 to 20% of patients with Parkinson's experience apathy, and this might just be that lack of motivation from that dopamine deficiency. So these people or these patients might have, they know they should exercise, but they're just not motivated to do so. Okay, so those caregivers in the room, it's part of the disease process, and we try to make that really apparent in physical therapy. Also depression. If someone might be feeling depressed about their diagnosis as a whole, they may not be willing or very excited to do exercise either, or motivated on the same sense. And then, of course, comes anxiety, which is about 70% of our patients with Parkinson's disease. And a lot of members will tell us this, Erin, I love coming to therapy, but it's really hard for me. I get really anxious to come park in the parking garage or even stand at the desk and have to register and be in the waiting room. Their tremor might be more aggravated. They may be feeling like they stand out in the waiting room as a patient with Parkinson's. So this anxiety can also impede them in participating in physical therapy. And in the interest of time, we're going to skip right into some fun.
Okay, so like Erin said, I'm Christine Shade, also another neurophysical therapist. So for my part, I'm going to do some different activities with you guys. So everyone needs to get their hands free. Perfect. So people who were in my group yesterday should be primed and ready for this. So we're going to warm up with just clapping our hands together and then snapping. So clap, snap, clap, snap, clap, snap, clap, snap, clap, snap. Perfect. Now, we know with Parkinson's that people have a really difficult time multitasking. So we're going to do our clap snap, and at the same time, I would like it if you could count backwards from 100 by fives. So what that's going to look like is, so we'll all start with 100 with our clap. So ready? 100, 95, 90, 85, 80, 75, 70, 65, 60, 55, 50, 45, 40, 35, 30, 25, 20, 15, 10, 5, 0. Perfect. You guys look pretty good. So that is a great exercise to do for yourself because we need to make sure, outside of just, walking and biking, we need to make sure that everyone is challenging themselves and making sure that you can still try and walk and talk or, talk on the phone and take notes at the same time. So other activities that, would be good when you're walking at home. If you're safe, you can walk in your hallway and try counting. You can also try walking and looking around and seeing and naming off all the plants that you see or the flowers that you see. You can also walk and read street names. Or when you're doing the stationary bike, a lot of times people want to pedal and watch their favorite TV show, but it would actually be a lot more beneficial if you could pedal your bike and then at the same time, read a magazine article or a great Parkinson's article. And then, so the bottom line is medication's not enough. So exercise targets motor and motor symptoms. So exercise actually helps motor-wise. It helps with rigidity, bradykinesia, and incoordination. It helps emotionally. It helps with depression, anxiety, apathy, fatigue. Cognitive-wise, it does help improve attention, executive function, dual tasking, and it can help improve sleep, decrease constipation, and decrease pain. And medication does help motor, right? It helps decrease rigidity and decrease bradykinesia, but it doesn't help emotionally, cognitively, or autonomically. So that is our piece with physical therapy.
Thank you. I thought she was going to ask us to go ahead and tap our head and counterclockwise go ahead and rub our belly at the same time, which I could never do even as a kid. So I also wanted to mention that Christine is actually one of the newest members of the PANC board. So you'll be seeing a lot more of her in the future. I'd like to now introduce Renee Gardner. Renee is actually a speech therapist working with the Sutter Group, works with Dr. Thacker and Linda. And so when I think of speech therapy, when it comes to Parkinson's disease, we tend to gravitate towards thinking about Lee Silverman vocal training. Many of our patients tend to have a softer pitch in their voice. And that's the reason that we make these referrals to speech therapy. But I think that their scope of practice is much broader than that. They can help also when it comes to swallowing difficulties and do swallowing assessments, even though they're called speech therapists and not swallow therapists, but also traditionally speech therapists do a lot of cognitive rehab. So this would be a great segue to have her come up here and talk about the work that she does and impart some pearls to you folks as well.
Thank you, thank you. Hello, everybody. It's a pleasure to be here. And so let me just say our business cards, just so you know, so often people will say, a speech therapist, my speech is okay in some cases or not in other cases, but we actually work with speech, language, swallow, cognitive, and voice. So we actually work with several different disorders. And so I recommend if any of you, in this process of me sharing with you some of the things that I'm going to share related to speech, swallow, and voice, if you have any questions, I would recommend that you write them down, and then we can try to cover them with the panel. Also, please consider asking your neurologist for a consult for a speech pathology consultation or initial evaluation. Next one. Okay. So oral motor exercises. I'm a strong proponent of engaging in oral motor exercises to keep those muscles, the lips, the tongue, working at their best and optimal ability. So these are a list of some oral motor exercises that are strongly recommended. The first one is smile with an exaggeration. Smile, hold that for 5 seconds, and then relax, smile again. And the second one is to pucker your lips and hold that for 5 seconds. Relax, hold for 5 to 10 seconds. Relax. Next exercise is smiling and puckering. And the best way to remember this exercise is to rotate with your vowel sounds. Ooh, ee. Ooh, ee. And again, the goal is exaggeration with your oral motor movements. Really make those movements as bold as you can and exaggerated as you're able. Number 4 is open your mouth and move the tip of your tongue around your lips. We do that for number 4 and number 5. There we go. Got it. Open your mouth, number 5 is in the gum line. Number 4 is moving your oral motor movements outside. Number 6 is open your mouth as wide as you're able. Hold that for 5 to 10 seconds and repeat. Think exaggeration. That's the key. Exaggerate the movements because the rigidity of the muscle movements is what we want to try to combat as best we can. Exaggeration. That's the key word I want you to remember. And then number 7 is to say loudly the sound with the base of the tongue elevating for ka. Ka. Sometimes you want to hold that. Ka. Number 8 is my absolute favorite because you're exercising the tongue base, the tongue tip, and then your lips together for the combination of pataka, 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 pataka. If you remember anything from these oral motor movements, please remember exaggeration and try to remember this syllable combination. Pataka, 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 pataka. Lip closure, tongue tip elevation, and tongue base elevation. Pataka, pataka. Singing. Singing is sustained talking. It's one of the absolute best exercises that we can do, talking and singing. And I am a strong proponent of asking patients to sing as often as possible. Many of the patients I work with put on a YouTube some of their favorite performers. One of the favorites is Frank Sinatra. So you put on the YouTube and you get to sing along with Frank. Fly me to the moon. whatever your favorite songs may be, sing along with Frank, sing along with some of your favorite artists. And it also helps maybe allow you to take a little stroll down memory lane. So strong proponent of that. Many of the female patients don't really like to do the gender thing, but some of my female patients love to listen to musicals. And so many of the female patients, male patients as well, but plug in some of those old musicals and sing along with them. One of my personal favorites is Mary Poppins, and practicing all of those sound combinations, supercalifragilisticexpialidocious, exaggerating, and then also having your spirits lifted a little bit by the power of music. The LSVT Loud program is the program that was discussed. And I have a lot of details that I'm not going to go through, but they will be provided for you if you want to read through them. Essentially, what I want you to know is this is gold standard research. It's an excellent program. Dr. Thacker and Linda refer many of their patients for this who have very, very many positive outcomes. So it's a program where you are practicing an intensive program of 4 days a week for 4 weeks, 16 intensive sessions, very hierarchical. And so the goal being bombardment, that you're practicing using your speech system in a louder, stronger, more exaggerated way. And with the results of this, 90% of the patients improve their vocal loudness from pre to post treatment. And approximately 80% of the patients maintain treatment improvements in their voice for 12 to 24 months post. Many order the DVD, which then allows them to practice and keep the reinforcement of that louder, stronger voice. So I'm a strong proponent, and if you're in question of it, please talk to your neurologist. He or she will know if they feel like you're an appropriate candidate. If they're in question as to that, please come and see a speech and language pathologist. Most insurances do reimburse. I do recommend that you contact the insurance to find out first. And then listed, the LSVT certified therapists are listed based on zip codes. So you can go online and find out if there's a certified clinician in your region and or the closest region where you can find a certified speech and language clinician. Be active and be engaged. Use your speech. Use it. I recommend that you engage in games that allow you to use word finding abilities, outburst, word search, Scrabble, finish the lines. Also, it's important to practice reading aloud. So if you're reading a novel or you're reading an article, take a paragraph and practice reading it aloud using that good breath support. Take a breath and then read. Take a breath and then read. Also, one of my favorites is to have patients record themselves, record some stories of your life. I have patients that resist that at first, and then it's amazing how much fun it becomes for them. I now have safe swallowing strategies. Sorry for this segue. We have a lot of information to cover. I will just tell you the highlights are small bites, thorough chewing, small sips, swallow twice after each bite or sip. Do not talk or laugh while you have food in your mouth. If you have some really funny friends, please ask them to keep the humor for after the swallowing. So you want to think, swallow. And really, this is something we should all be doing. It's called mindful eating, so that we're actually thinking about the swallowing as we're doing it. If any of you are showing some signs or symptoms of difficulty with the swallowing, again, that's a conversation that you want to have with your neurologist. It's important to stay upright for 15 minutes after eating, and then always to have oral hygiene after your meals. All right, thanks everyone, and if you have some questions specifically related to what I've shared, please don't hesitate to write those questions down, and I'll be happy to try my best to answer them. Thanks.
Thank you, Renee. So at my house, we have Katy Perry on repeat because of my kids. Does that count, or does it have to be Frank Sinatra? No. Okay. Katy Perry is good. Katy Perry's okay? Okay. I'm getting sick of it, but my kids are not yet. Unfortunately, I'm going to try to break that record if I can. All right, our next speaker is going to be Dr. Eric Egli. I have had the pleasure of working with Dr. Egli for almost 10 years now. Dr. Egli is a licensed psychologist working at Kaiser Roseville. You might wonder, why would I make a referral to a psychologist when it comes to Parkinson's management? I do for a variety of reasons. One is simply because I need patients to be able to recognize the fact that they have recently been diagnosed with a neurodegenerative condition. And he has wonderful tools and strategies to help patients understand what this means for them, what the trajectory looks like for them from a psychological standpoint. Secondly, I also make frequent referrals to Dr. Egli for those people who may be eligible candidates for deep brain stimulation or are a little anxious about something like neurosurgery. So he helps with anxiety reducing strategies as well. So he's been a tremendous help to our PD community up in Roseville. So without further ado, I'd like to introduce Dr. Egli.
Hello, good to see everybody here. As a psychologist, I'm hearing people talk about mood and mood effects and things that we know can be a direct result of the neurological implications of Parkinson's, but also obviously a result of the challenge that having a disorder means. And but just as with the other speech therapists and the physical therapy, just because it can be part of the disorder doesn't mean it's not something we can work with. So I think it's really important to keep that in mind. And the focus I'm going to take here today is really to discuss the kinds of things that people experience as normal, not pathological. We talk about words, we say words like anxiety, and we say words like depression. It makes you sound like you have a mental illness. Now, some people do, of course, but that's not what I'm talking about. I'm talking about most people with Parkinson's. The majority do not have clinical depression. They do not have clinical anxiety, but they struggle with day-to-day issues related to their disorder or their disease, and that is common, whatever the condition is that a person has, cancer or MS or just getting old and getting debilitated. So I'm really wanting to talk about language a little bit, different ways of thinking about it other than using the words that we associate with pathology or a mental health problem. Maybe you don't feel so stigmatized having to see a psychologist. Maybe you're not sick. Maybe need a little guidance. So I think that's the kind of thing I'm talking about here. Okay. So I've got to figure out which button here. Okay, I think this one. What is normal when you have a chronic, progressive, disabling, and so far not curable condition like Parkinson's? We have hope, right? Another question that people might have is, when do normal and natural, healthy, but not really positive emotions become something to worry about? I mean, if people didn't get troubled by some of the challenges that they're facing, that's when I would worry about their mental health. I think we want to talk about it a little differently. Like when we have grief or loss, we expect people to be sad. It doesn't mean it's not healthy, but it also is something we may not want to bathe in any more than we need to. But we want to acknowledge the feelings. And I think and part of how do we look at these has to do with how we cope with the losses that we're experiencing in day-to-day and year-to-year time, and redefine life as you go through that journey. And that I'm talking about the person with Parkinson's and the person with Parkinson's. So we have words like depressed, but let's talk about normal terms that people have. I'm demoralized. I'm frustrated. I'm resentful. I'm very disappointed, sad, alienated, or I don't want to be seen. I mean, all of these kinds of things that people can experience in life. If we use these words, these are natural and normal and understandable in the context of what you're dealing with. It's not pathology, okay? And we can try to address them and think about how do we talk about that. Let's talk about anxiety. I'm worried, yeah? Concerned for yourself, for your loved one, fearful. We can acknowledge these. Agitated, apprehensive, edgy. All of these kinds of things are things that people can be feeling in their day-to-day life. And I guess the point I want to make is sometimes when people express either verbally or express non-verbally by withdrawing or by being cranky or various sorts of things, when they express them, we don't have to. The natural urge, especially when you're a loved one, is to try to make them not feel that way. Don't feel so bad. Don't feel so bad. Partly if you feel bad, I feel bad because, I care about you, right? But also, we want them to feel better. So we try to talk them out of these feelings sometimes. And I think what we really need to do with these feelings is acknowledge them as normal and healthy, and yet we don't want to bathe in them. They're part of our lives. They're part of our natural experience of life. And all of us who are at this point in life have had multiple challenges in life, probably a number of failures and things that haven't gone right. We push through them. We find ways through. And so people have coping skills. So a lot of the people that I see, these are the words that I would use for most of the people that I see. I see people who are resilient and strong, who have determination, who are resourceful, committed, positive, caring, courageous. People who do can thinking as opposed to can't. In the process of loss after loss, it's easy to get caught up in what you can't do, what you don't have in your life. It can be very challenging to shift to a mindset, okay, I acknowledge this loss. What can I do? Where can I move from here? What can I shift some of my interests to other things that really give me joy or pleasure? So that's what I'm talking about, can thinking. And one last thing is, I always cringe, as a psychologist concerned with relationship, I cringe at I'm the caregiver, I'm the care receiver. That should never be the primary, unless that is the paid occupation, that should never be the primary, description of one's relationship. We are life partners, and we go through many different things together. Anyone who's been married a long time has gone through a lot of different things with their loved one together, okay? And sometimes we do have to be a caregiver, but that doesn't define who we are. I've decided I kind of almost like the term co-patient when it's related to something like Parkinson's. They have codependent, right? There's an alcoholic, there's this and that, and because your life is so involved with what's going on with the other person, right? So if you see, everyone goes in together to see the doctor. Doctor, what's going on? What should we do? You got a patient, you got a co-patient. I think in that context, I kind of prefer that. Never thought of it before, but I kind of we're a tag team, right? Sometimes you help me, sometimes I help you, regardless of your condition. Sometimes I help you just by being a thoughtful, kind person. That can be immeasurably helpful to a person who is a caregiver, for example. Just how you interact together. So we take care of each other the whole way through. That's the goal, as much as we can. Accomplice, lover, those kinds of things, that's what we want to be with our partners regardless. So that's my talk, and hopefully stimulate some questions. Thank you.
Thank you, Eric. I think that that right there probably resonated with most of us. And something that we really need to shift in our philosophy when it comes to how we look at this condition. And it isn't necessarily just unidirectional. It really needs to recruit a multidisciplinary approach and multiple factors when it comes to a support network. I have a lot of patients that come to my office looking for a sense of community, and that isn't something that they understand or can appreciate. I want you guys to look around. There's 500 people in this room right now. This is your Parkinson community. This is amazing. This is one of the largest gatherings of Parkinson patients in Northern California for the whole year. I'm not sure if you guys recognize that. But for us that are up on this panel, for Dr. Thacker who spoke earlier, this is an impressive bunch. And I really want you guys to look to your right or to your left of you and thank that person for bringing you here, joining you to be here, because this, again, is your network. This is your support. So I want you guys to take a second and actually do that now. If you don't know the person on your right or left, introduce yourself. Okay. So now I'd like to introduce our movement disorder specialists. Sacramento has been blessed with 4 large health institutions. Kaiser, I'm going to have to say that first because I work for Kaiser. Sutter, Mercy, and UC Davis, not necessarily in that order, no offense, okay? But only up until recently have we actually had movement disorder neurology at each of those locations. Currently we have 4 movement disorder neurologists at UC Davis. I'm at Kaiser, Dr. Thacker's at Sutter here in Sacramento, and now we've been joined by Dr. Hadi. When I first heard his name, I heard Hadi, H-O-T-T-I-E, Hadi? It's kind of arrogant. Who does he think he is? He's from Grey's Anatomy or something. But now that I've got to know Dr. Hadi, he's been a wonderful addition, not just to Mercy Dignity, but also to the movement disorder community. So Dr. Hadi actually trained with Dr. David Swope down at Loma Linda. In fact, he actually knows my brother who also trained down there too. So it's kind of interesting how that came about. But now he's here, he's in Sacramento, and we love to hear from him now. Dr. Hadi?
Okay. Thank you, Dr. Khandhar. It's impressive. This is beautiful, and this is the kind of gathering, I think, that helps support this condition, help support each other. This is beautiful. So Dr. Khandhar actually gave me 10 minutes to talk about Parkinson's disease, which I thought was a little bit tight, but so I thought the best way to approach that is to give how I approach a person who are newly diagnosed with Parkinson's, and what kind of overview I give to them about this condition. So Parkinson's disease. What is Parkinson's disease? It is basically, by the way, this talk is probably not going to be as fun as the talks we've had before me, but I'll try to keep it a little bit fun. So it is a neurodegenerative condition. Fortunately, it is a slowly progressive condition. So it is not like a condition like stroke or multiple sclerosis where you have sudden drastic symptoms. This is a very slowly progressive condition which helps adapt with the symptoms as well. So, and it is the second most common neurodegenerative condition. What causes it? We're not entirely sure there's one specific reason to get Parkinson's, but we know that multiple factors are contributing. Are there some genetic determinants? Most likely, especially when we see an earlier onset. Some environmental exposure, certain professions, certain toxins have been known to be implicated. And then are there other mechanisms such as some inflammatory process, changes at the cellular level? All these changes have been noticed or noted in Parkinson's disease. Then what is the kind of pathological changes that we see? There's these, Dr. Thacker mentioned about Lewy bodies. That's the pathology that we see in Parkinson's, and with that we see these abnormal proteins, alpha-synuclein, which is probably the basis of all the pathological process that takes place. But all of this, what does it lead to? What it leads to is decrease in dopamine level, which is the main brain chemical that leads to the symptoms of motor symptoms of Parkinson's. So what are the symptoms of Parkinson's? Broadly, they can be divided into motor symptoms and non-motor symptoms. So motor symptoms, these are the symptoms that we see. So visually, we can see in someone who we diagnose with Parkinson's. And the cardinal features of cardinal motor symptoms include slowness in movements, stiffness in the movements, tremor or shakiness, or changes in or balance changes. And what about the non-motor symptoms? Now that is the most important aspect of Parkinson's, I believe, because that's something that we don't see, yet it can affect the quality of life. And unless we address them, we won't be able to improve the overall quality of life. So this is a beautiful picture by Dr. Langston, who talked about the tip of the iceberg. And what we see is the motor symptoms, and we can see below that there's so many other areas of the brain that we see the Parkinson's pathology in. And most likely, those changes lead to the non-motor symptoms of Parkinson's. And you can look at the list of these non-motor symptoms, way more than the motor symptoms. And that is why it is so important to address some of these symptoms. And some of these symptoms are, easy to address, like, simple things as drooling from the mouth. It can be embarrassing. People don't want to go out and be around people or friends. So these can be easily addressed. Constipation, sleep disorders, very important, because if we do not address sleep, we won't be able to improve motor symptoms or improve the quality of life. Orthostatic hypotension, dangerous symptom, can lead to falls, injuries, fractures, so easy to fix sometimes. Urinary symptoms, so a lot of symptoms, mood, depression, anxiety, weight changes, pain. So a lot of these symptoms we don't see. So these are the non-visual symptoms, a lot of things we don't see. So it's very important that these symptoms are addressed during our visits. I try to cover them, but most times I can't. So it is very important that each one of you addresses these symptoms with your providers and bring them up so they can try to address them as best as possible. Maybe it means less medicine. Maybe it means some other approach to these treatments, alternative approach. So please bring them up. How should Parkinson's be managed? We have a medicine for a lot of symptoms of Parkinson's, but just because we have these medicines doesn't mean you get on these medicines. Everybody with Parkinson's this is their Parkinson's. It's going to be different from the next person sitting next to you. So just because one person is on this medicine doesn't mean everybody has to get on. So it's a very personalized kind of treatment for Parkinson's. So that's why we have to address the person as a whole. We can't just say, well, you have tremor, here's a tremor medicine, that's it. Or you have dyskinesia. For some people, dyskinesia is not even a problem. So don't have to address that. That's probably the time that they're feeling the best. So we have to address the person as a whole and see what is the symptom that's bothering them the most, because we know that there's no cure. So if there's no cure, how to improve your quality of life? That's a symptom we need to address. Support, caregiver. The caregiver is the biggest, I think that's a coach. And if we don't help the caregiver, we won't be able to help the patient, because they are their lifelong partners, as we just heard about. And so we have to be able to help educate, provide all the support that we have, like these occasions, and see how we can help them help their partner. Medications, always we have medications. And we have to be careful with the medications because they have their advantage and risks and benefits. So we have to address them in that way. Alternative approaches, exercise, therapy, behavioral therapy, cognitive behavioral therapy, physical exercise, occupational therapy. So all these approaches are available, and we have to use them as best as possible, as much as possible, because they'll sometimes help reduce the medication load. Future developments, I mean, amazing. Who would have thought about 15, 16, 17 years ago that we'll have a device in the brain to control symptoms of Parkinson's? So things have just exploded in Parkinson's. And newer medications, like Dr. Thacker mentioned today, a lot of new medications are being looked at. Stem cell therapy now is safe, and so we just are looking at, researchers are looking at how best to utilize that. Newer devices are being looked at. So sky's the limit. I think there'll be a lot of newer developments, newer medications, newer strategies that'll be available soon. So in summary, Parkinson's disease remains a slowly progressive degenerative disorder. We have to address both the motor and motor symptoms to improve the overall quality of life. Medicines alone won't do it. And everybody has their own treatment. Everybody's treatment will be different from the next person. So keep that in mind and make sure these symptoms are addressed with your provider, bring them up, and discuss what would be the best personalized care for yourself. Thank you.
Thank you, Dr. Hadi. So our next and last panelist is Dr. Norika Malhado-Chang. I've known Norika here for almost 10 years, I think. And she actually did her training out at Mount Sinai University in New York, did her training under a very gifted DBSer by the name of Michele Tagliati, and then she moved out this way to Sacramento. She currently has helped to shape the UC Davis movement disorder program as well as the residency program, and is very much involved in educating the residents and fellows that are there now. So I'm always appreciative of her help and her expertise. I'd love to hear what she has to say.
Thank you, Suketu. This is really a great opportunity. Thank you so much for inviting me. I want to give a shout out to PANC. The Parkinson's Association is really a remarkable organization to create this kind of event. I mean, it's just so amazing to have this kind of an audience and representatives from our 4 major health centers, at Mercy, at Sutter, at Kaiser, and at UC Davis. Believe it or not, we're all friends, and we're all friendly, and we get along really well. And I think this is such a cohesive community. It's really been a pleasure for me to practice in. I represent UC Davis, and I'm honored to have the opportunity to be involved in teaching. I conduct all the medical student courses and teaching medical students how to be doctors. I teach residents how to be neurologists. I teach neurologists how to be movement disorder specialists. And what's most near and dear to my heart is Parkinson's disease. I eat, live, breathe Parkinson's disease throughout my career. In 2001, after my career started, I diagnosed my mother with Parkinson's disease, and just a few years ago, my father-in-law with progressive supranuclear palsy. For those of you who aren't familiar, is an atypical form of Parkinson's, which is both really challenging diseases to deal with, and especially when it's your family members. It's a completely different situation, and so I understand. I really do. I'm living it myself, so a lot of these recommendations I take to heart for myself as a caregiver. I'm so excited that this topic today is on non-motor, because non-motor, I think, is an area in Parkinson's that is probably the most neglected, but is arguably the most important, because it's the non-motor symptoms that really correlate most closely with quality of life. And I see a lot of familiar faces, and you guys have, this might be repetitive from our visits because I talk about this all the time in the office. The non-motor symptoms are the symptoms that really make or break your experience of life fighting this disease. We have medications for the motor symptoms. In fact, we have the most number of treatment modalities available for the motor symptoms. It's the non-motor symptoms that we don't even recognize are part of the disease, right? So sometimes when I'm talking to patients, they're like, wait a second, my bladder is not because of age, it's not, the constipation is not because of my diet, that's part of the disease, no way. So it really makes such a difference to be able to empower patients to recognize, wait, this is actually something that's not normal. It's not just me that I'm really feeling no motivation, no energy. I feel like I can't get up and go to exercise because I'm just feeling down. And that's not you. That's the disease. And we have to recognize that all of these pieces come together, and we have to address them. And once we give them that value, that recognition, then we can begin to address them. So some of the things that we talk about routinely, and I want you guys to bring up with your providers, are things like feeling lightheaded when you stand up, right? Feeling lightheaded really impacts your ability to get up and go because you just rather sit down. Feeling like food is not as pleasurable, right? Because your sense of smell might not be as keen, and so if your sense of smell is not so keen, maybe food does not have the same pleasurable effect. How about speech? If people can't understand what I'm saying, I might just be less interested in socializing and might tend to withdraw or just rather stay home than go out with my friends. Problems with bowel, bladder, sleep. Oh my goodness, sleep is has such a big impact on quality of life because there's not one person in this room, I guarantee you, who has normal sleep. And that is probably the biggest determinant of daytime energy, right? So daytime energy is what can make or break your motor symptoms. So if you think about it, if you're tired during the daytime, your balance, your tremor, all of the motor symptoms are going to be affected as well. So these are all aspects that I think once we recognize are tied together, we can begin to address them. And I think this is very empowering for all of you because I want you to bring them up with your doctor and tell your doctor, you know what, I'm recognizing, I think this is part of my Parkinson's. What do you suggest we do about it? So anyway, we're very happy to welcome any questions. And again, thank you all so much for coming.
So thank you, Norika. So this is actually now where the real fun begins, and this is where you're going to see the panel pop. So I have a few questions that I'm going to ask before we break for lunch. We have about 30 minutes, and then we'll have our lunch break. Of course, during that time, you're going to bring up your questions, and then we'll start again about 30 or 40 minutes afterwards. So first question I'm going to pose to the panel, and I think this is a question for nearly everybody on the panel, is that my mentor at UCSF once told me that the most important part of a Parkinson patient's day is whether they had a bowel movement or not. So how do you address constipation in PD? Now, this may not be a question for Renee so much. I would imagine speech therapy, constipation may not have as much of a value, but I'd like to pose to everybody else, constipation. Let's start with Dr. Hadi.
So constipation, like Dr. Khandhar said, is a very important symptom. So basically what I suggest people is, keeping physically active, well hydrated, adding supplements to diet. Now, usually I suggest high fiber diet. There's a rancho therapy which was suggested for Parkinson's. So those kind of therapies, and then looking at other supplements that we can use on a regular basis. And other than that, obviously you want to rule out if there's any other pathology or etiology going on, but most of the times we know those screenings are taking place. So in general, those are the kind of things we suggest for constipation.
So you mentioned physical therapy and being active. What do the therapists think about that?
I was going to thank Dr. Hadi, actually, because he said it already for us, right? Physical activity. So I was going to thank him because he already hit on it for us, that we let our patients know that if the more active they are, the more likely and more bowel motility they're going to get throughout the day. So we just remind them that exercise can actually help them with constipation.
Christine, anything to add?
No, just move every day, and hopefully it'll help other things move.
Now, Dr. Hadi mentioned the Rancho recipe. So this actually is a recipe that came out of Rancho Los Amigos, which is a rehab hospital down in Los Angeles. And they came up with this recipe that has a lot of natural fiber supplements in it, like prunes, for example. And then people took it a step further. The VA Medical Center actually came out with something called the prune whip, which basically is a combination of pitted prunes and oatmeal and wheat bran, and basically kind of conformed into a pudding. And I get the batch makes like 10 cups of this pudding, which is a wonderful fiber supplement for patients. I often give my patients that recipe, but what do you do, Norika?
I don't know if this is on. Yeah. Okay. So one thing that's important is the understanding that constipation and the slowing of bowel motility, that means the intestines are slowed, just like the movements of one's arms and legs may be slowed. So it's not something that is a once in a while sort of thing. This is something that we have to think about all the time and try and prevent on a regular basis. So what I don't think is appropriate is using medications on an as-needed basis, waiting until it gets to, well, maybe when I get to my 4th or 5th day without a bowel movement. I think that becomes really problematic because then we're always behind the 8 ball with a bowel movement. The goal is really to have a bowel movement every 1 to 2 days. So if we wait until 4 or 5 days, it gets troublesome. And then the American Academy of Neurology did study different types of prescription medications used in constipation, and the outcome was that if we are going to use a prescription, agents like Miralax turned out to be the best for long-term use, as opposed to things like enemas and suppositories and things that we really want to try and avoid, just because this is, again, not a one-time situation. This is an ongoing issue that we need to be on top of before it kind of runs away with us.
So I absolutely agree. I think that we have to understand the pathology and sort of what's normal with the intestine. So the intestine is basically this big tube that's folded upon itself multiple times in the gut. And along the length of that tube, there are bands of muscular tissue that synchronously contract in order to allow that stool to move along, like a toothpaste container. And when those contractions are weak, the stool stays behind. The actual purpose of the gut is to remove nutrients and water from that stool. So the longer that stool stays in there, the more it adheres to the lining, the harder it gets, and the more the bacteria within the gut start to work on it, producing basically more gas, to where patients feel bloated and really can't move that bowel along. So for me, the recipe of success has always been natural fiber, flushed with water. You can't do the fiber without the water, okay? And then the Miralax. And the actual purpose of Miralax, and not Mirapex, that's different, Miralax, which now is over the counter, basically draws water back into the gut. That's its mechanism of action. So that sort of, that triple threat is wonderful for people, most people who have constipation and PD. Dr. Egli, do you have something to add?
Yeah, I think so. It all gets back to psychology, right? Nothing works if you don't do it. And whether you do it or not is all about what's upstairs and how your partner and people work with you and how everyone else works with you. So So even something basic like to do something on a regular basis, or whether it's drinking water or something, we have to think more than just say, do it, right? Sometimes people need guidance, instruction, behavioral suggestions, structure to do it. For example, putting out a certain amount of water or putting out things in a certain way so you see what you need to do if you're not naturally thirsty or something else like that. I mean, there are ways of structuring things in the day to help you adhere to what the guidelines are, because that's what really makes the difference. So.
Oh, that's good.
I'll also add to that, too. I totally agree. One of the comments that I get often is, yeah, the constipation is not part of my Parkinson's. I've had that for 20 years. And it's been ongoing. It's been a lifelong issue. And it probably has been going on for 20 years because we now know that that's actually where a lot of the pathology starts. So it's not just a symptom of Parkinson's since you've gotten your diagnosis. Parkinson's probably starts in the gut. This is a whole other conversation, but yes. I won't get into it too much. But it's actually a very, very early sign that usually precedes the actual diagnosis by about 10 to 15 years. So all the more reason to be on top of it and not let it get behind.
So basically what you just did is increase our referral rate for people who simply just have constipation. Thank you. No, but she's absolutely right. We'll move on to the next question. So as PD advances, speech difficulties become more obvious. Softer pitch in the voice, difficulty articulating, and difficulty expressing thoughts, all of which can lead to social embarrassment, social isolation, and depression. Can this symptom and how can this symptom be tackled? I'll start with Renee.
Well, it is an adage that we often say, it's an old adage. You've got to use it or lose it. And so it's very common for folks that have difficulty with their verbal expressive abilities to become more reclusive and to use their speech less and to become less involved communicatively. And that's the absolute worst thing that one can do. And so what I encourage patients to do is, based on the listeners, not all listeners are created equally, as you all know. So I think it's important to let people that maybe are new listeners to you to tell them, I have Parkinson's disease. And so would you please be patient with me as I express myself? And it's important to continue to use those muscles and to continue to talk. Read aloud, talk, and sing.
Eric?
I'm 100% on that. Obviously the isolation itself becomes a problem. It can exacerbate depression and moods and other sorts of things. What I will say, is that people who are dealing with things like disfigurement. I worked on a burn unit for some time also. You find out that there are certainly a number of rude people out there in the world. They don't really have to be the core people in our life, hopefully. But what does seem to happen in the end is when you're honest about what's going on, people react to you essentially the way you project yourself in a lot of ways. So if I project myself like I'm really self-conscious about this and I'm really awkward about this, and I don't even really want to be talking to you because it's so hard, the other person's going to react with that same kind of discomfort. And then that can increase the anxiety or increase the stress to the interaction. So when you're really getting out there, it's really a good idea to try to be as okay with yourself as you can be, that this is what's going on. You didn't want it, you want it, take it. That's fine. But I mean, this is a reality. But the degree to which you can project that this is just matter of fact and this is the way you are, then the other people around you will be more comfortable, and as such, they'll be more accommodating and want to work with you to make it work.
I think on that note, one of the biggest challenges, at least for my clinic, is that when I see patients becoming more socially isolated, and they feel that this is a social embarrassment for them, and they start to regress and have less social engagement. So I'd like to hear about from the therapist, what things do you guys do in your clinic to try to encourage social engagement?
We definitely encourage everyone to go to support groups. So you go and you are with your peers and you see other people that are having the same issues and you get to talk loud and talk about it. and definitely in our appointments when people are trying to communicate. A lot of times their co-patient will try and speak for them, but it's really important that you try and speak for yourself and you try and talk loud. So we encourage that throughout. Also with our exercise groups, we definitely incorporate voice and trying to be loud throughout the time.
I think one highlight on the exercise groups is that we've developed exercise groups for people with Parkinson's to come, because if they might be a little apprehensive to go work out in a gym for a lot of the reasons that have been brought up, they're able to come to a setting where they are with others with Parkinson's. So there might be a little less apprehension. So I think that's been a great way for us to also address that in that setting.
Dr. Hadi, is this something that you discuss with your patients?
Yeah, this actually emphasizes the importance of multidisciplinary approach in Parkinson's, because we can address certain components and then we need to have all these other aspects, all these other fields to help with overall improving quality of life. So from that point of view, first of all, we have to kind of see if there's these speech issues, is this because of an underlying depression going on? If there are underlying mood issues going on. So we try to address those. And then along with that, obviously, having the input from our speech therapists, physical, occupational therapists, I think those are that's the best way to approach these kind of issues.
Okay, so I'm going to move on to the next question. Many of our patients and their loved ones are concerned about excessive daytime sleepiness. And I want to know, because actually you brought this up, Norika, what's your approach to excessive daytime sleepiness?
So excessive daytime sleepiness is really multifactorial. It is not just the medications, although I think that's one of the places where everyone tends to harp first. Sleep, nighttime sleep is addressed routinely in my visits because it's not one of those symptoms that we think about because we're asleep. We don't realize that our sleep is really disrupted and it's not normal. It's not normal to be moving around while you're dreaming and acting out dreams and talking, or snoring excessively, or stopping your breathing during sleep, or not being able to get to sleep for an hour or two because your legs feel really restless and you have to move them. So, or another one is having to get up every 90 minutes or so, or every 2 hours without reason. I don't really have to use the bathroom, but I'm just finding myself awake, and I find myself awake multiple times during the night. We call that sleep fragmentation. So I just named several different causes that probably resonate with a lot of you, and don't think that you're going to have energy during the day if these things are going on at night. So one of the things that I do is try to pinpoint some of the more obviously treatable sleep situations that are disrupting the quality of nighttime sleep. We focus on what we call restorative sleep. That helps significantly. Then we also work on ways to improve energy during the daytime, short of changing around medication timing or the medication burden at any given time. Sometimes lowering doses more often during the day is helpful. Of course, activity, right, and exercise. Usually our dopamine levels tend to come down and reach a low point in the late afternoon, like 4 p.m. or so, partly because our energy is depleted for the course of the morning and the day, but also because that's a natural sequence of events. That's the time not to be idle. That's the time not to be sitting and watching TV because you'll be out in 2 minutes. So I usually recommend that's the time that we do scheduled walks, getting out of the house, or scheduling a social event or physical therapy during that time. So there's things that we can try and do to optimize sleep at night and maximize energy during the daytime. Taking naps during the daytime kind of sabotages us a little bit because that perpetuates the cycle of not having really good deep sleep at nighttime. We always see that when there's a good night's sleep, our motor symptoms are better the next day. So this is a really important issue.
I think so, and I think that's going to bring me to Dr. Egli. I wonder if you give your patients any kind of tips or tools when it comes to sleep hygiene. I know one big one that I tell my patients is turn this off when you're lying down in bed, okay?
Yeah, you may not realize, but I do a sleep program And I go to the sleep conference. I was in Seattle last June. And so, sleep is a vital, function for all of us for many, many different reasons. And, most people with chronic long-term insomnia, it actually is a behaviorally derived, phenomenon that they experience because of habitual behaviors and things that they do and don't do inadvertently that wind up sabotaging their sleep at night. Now, when you have something like Parkinson's that by itself can also contribute to sleep problems, but you also don't know what not to do, then you compound it by all the behavioral things that everybody else does that messes up their sleep, and then we really wind up off to the races. And so, we talk about sleep hygiene, just like you're talking about, having, that's what we've heard, reducing naps, having increased daytime activity, not having bright lights on at night, having the lights way down as dim as possible. They can drastically affect your circadian rhythm. Big screen TVs, a lot of blue light can really mess that up. What you do when you do wake up in the middle of the night, so that you don't exacerbate the problem, moving around too much or turning on TVs or your iPads. I mean, there's a lot of things that would go beyond what I have time for here, but the basic sleep guidelines may not get sleep perfect by any means, but it can certainly help, and we want to not further complicate it by things that we're doing that are aggravating the problem. And unfortunately, we do that because we don't know what to do. I don't know how much to go into that.
No, I mean, I think that, certain things that I tell my patients are that they absolutely should not be eating just before they go to bed. They should not be doing any kind of heavy activity just before they go to bed. Certainly nothing that's going to be very activating for them just before they go to bed. Unfortunately, all the best TV shows happen like at 10 o'clock at night. Try to avoid some of these presidential debates, reserve that, because that can be quite activating, at least the Republican national debate. But certainly turning off your cell phone at nighttime. For us in neurology, we can at least open up a neurology textbook. That'll put me to sleep right away. But what things can we tell our patients? I'm pretty sure nobody here has a neurology textbook. So,
I'd like to add that the experts, my greatest teachers, are my patients. And so I have a patient of late that we've been working significantly with his breathing. Working on helping to improve his breathing pattern for speech, to make his speech louder, stronger. Take a breath, then speak. But also, we've been working on Dr. Andrew Weil teaches the concept of a 4-7-8 breathing pattern. And you can YouTube Dr. Andrew Weil, and he'll walk you through his pattern of breathing. But this patient that I'm working with who has Parkinson's disease started working on the 4-7-8 breathing cycle of Dr. Andrew Weil, following along on the YouTube. And he said that he's been using it in the evening when he's having difficulty sleeping, and he's having some success, that it is helping him with the relaxation response, actually kicking in what we call the parasympathetic nervous system. That's the system that allows us to relax, to digest.
So somewhat recruiting a meditative type approach. Okay. So one of the challenges I see in my clinic is that sleep is hardly ever brought up in the neurologist's office. Okay, because a lot of patients are not quite sure that sleep is even part of Parkinson's disease. So they, in fact, will bring it up with their primary care physician. The knee-jerk reaction of the primary care physician is to prescribe a medication. We live in a prescription society, and that actually is very challenging to undo that process, to take patients off of these highly sedative medications that tend to be addictive in nature. So I would like to hear from Dr. Hadi. What do you do in those circumstances? Somebody comes to you, they have sleep issues, they've already addressed it with their primary care physician, now they're on a benzodiazepine like Ambien, like Restoril or something like that, and you can't get them off that, and now they're tolerant to it.
First of all, sleep is important from the aspect that we will hear from the caregiver, family member, say, he's sleeping all night, or she is sleeping all night. Yet, when we ask the person, they say, well, I don't think so, I was sleeping, I didn't get rested enough. So basically the first thing is to know, was this sleep restful or not? So is this, when you wake up, do you feel refreshed? Is it refreshing sleep or not? Now, a lot of times these medications, or just Parkinson's by itself, is doing that, is not giving you restorative sleep, as some of the other panelists have already explained. So these medications, we have to be careful what medications we use. There are certain medications that work better for sleep fragmentation. Usually these benzos and Ambiens and stuff like that, they are good for initially to make people fall asleep, but then to maintain that sleep, it's always harder to do that with these medications. So it's best to avoid these kind of medications. The other issues we see with these medications is also balance-related issues. So long-term use of these medications, dependency, tolerance, and then leads to falls and balance issues as well, and even memory issues. So we have to be very cautious in those kind of situations. And someone who's already on it, I don't say stop it, because it's not possible for them to stop it after being on it for such a long time. So the goal is to slowly get them off the medicine, usually wean them off over time, and then at that point, if need be, if there's no other issues that are contributing, then maybe introduce a better medicine, and trazodone is one of the medicines that we commonly use in that kind of situation. The other things, lifestyle changes like improving sleep hygiene, as Dr. Khandhar alluded to, those are kind of things, tie yourself to sleep. Don't do things that are stimulating at night. So basically, that's, it's kind of looking at all the aspects that we can help with the sleep hygiene.
So I'm surprised no one's brought up melatonin. What do the two movement disorder neurologists think about use of melatonin in Parkinson's disease?
Well, again, everybody's different, and so we have to really do it on a case-by-case, but it's particularly for patients who experience the real pattern of sleep fragmentation and REM behavior disorder. REM behavior disorder is what I was describing before with acting out dreams, talking during sleep. It may not be an obvious dream reenactment, but even just excessive movement. Melatonin can be very, very helpful. The dosage varies, though, and it's very difficult to get to figure out the appropriate dose. Doses go anywhere from 1 milligram per night all the way up to 15. So what works for one person is totally excessive for another. So we have to really try and figure what works best. Usually somewhere in the 5 to 10 milligram range, I think, is most effective. But it's one of those things where we have to, again, use it in combination and not in isolation. I don't think anything works by itself. It's such a multifactorial issue. It's not just about falling asleep. It's about staying asleep and having really good quality of sleep.
Okay.
Can I make?
Yeah, please.
I just wanted to put this out there. There's a brand new medicine out there for sleep called Belsomra. Labeled this year, you're going to be seeing millions of dollars of ads for it. At the low dose, the average increase in sleep was 14 minutes a night. At the high dose, it was 24 minutes a night. That's all it takes to label something for insomnia and to market market it like crazy. So just be wary of all of the happy butterflies that come in your window and things like that at night. I mean, they really oversell these things as much as they possibly can. I just thought I'd put that out there.
No, thank you. That actually is a very good point. Dr. Hadi, your use of melatonin?
That's actually, first thing is obviously trying to do some supplements, natural supplements. So melatonin is usually first line from that point of view, if we are to go from a medication point of view. So yes, that's commonly used. And for the same, sleep-related behaviors, not exactly REM behavior, but vivid dreams and, restlessness at night, those kind of activities. For those kind of behaviors, it is a suitable, very reasonable medication supplement.
Okay, I think that'll be actually a good segment to talk about urinary frequency. So this really fragments patients' sleep. For some people, it's that they have to wake up multiple times in the middle of the night. They may go to the bathroom. They may take a while to go to the bathroom. They may not even completely clear, and then again, have to happen again in the middle of the night. So I'll first ask the movement disorder neurologist, how do you guys approach increased urinary frequency, particularly as it fragments the sleep?
So there's two different kinds of bladder ailments that we deal with, and they're kind of opposites of each other. One is urinary frequency, and one is urinary retention, where the bladder fills and we don't have the appropriate messages going to the brain to contract. So the more common one is the frequency. That means always having the urge, having very short, limited span of time to get to the bathroom, and it always seems like that is more prominent at nighttime. So what we do is, again, this is many steps. It's not just one answer, medication being the one answer. We do try and limit the amount of fluids late at night, like after dinner. We try not to have too much fluids. Sometimes a medication, a low dose of a medication to try and relax the bladder is helpful. Those have to be used with extreme caution because they can have cognitive effects. During the night, we have to make sure that balance and falls are prevented to every degree possible. So we have to make sure that the pathway to the bathroom is clear, that perhaps there's night lights on. That's a prime time for falls. And because there's so many trips that are being made, to try and make those trips in a half asleep state is very dangerous. There's a lot of other modalities other than medications that are available, and again, depending on one's situation, they could be helpful or not. So seeing a neurourologist or a urologist or sometimes even a urogynecologist is familiar with things like tibial nerve stimulation, botulinum toxin injections. There's other ways to try and combat the issue when you're having to wake up, every 90 minutes or every 2 hours.
Now, going back to what you said before, you talked about limiting the fluid intake in the evening. Well, we just talked about a couple questions ago that we want to increase fluid when it comes to constipation. How do we manage that?
Right. So it's just a timing issue. I think there's no question that most people could use more fluids during the course of the day, for sure. It's just the timing. I think having all of that fluid after dinner time, when we remember, I didn't drink all day long today and I need to have my fluid intake, that's just not the time.
So I think that actually is important for us to talk about, is that what types of fluids make you go to the bathroom? Coffee is easy, right? You basically drink a cup of coffee, you go to the bathroom twice. Okay, it's a rule of thumb, okay? Water is sort of 1-to-1. If you have lemon in your water, the citric acid in the lemon, okay, is actually causing you to bladder contract, so you feel like you have to go to the bathroom more often. So even though it may make the water taste better, you got to go to the bathroom more frequently. Now, there is caffeine in soda too, okay, contrary to popular belief. So really trying to avoid caffeinated beverages the second half of the day, if and hopefully at all. But of course, Dr. Thacker talked about earlier about how caffeine has actually been used in Parkinson's disease to help alleviate motor symptoms and make people feel a little bit more alert. So you see the challenges when it comes to what should I be drinking, how much should I be drinking, let me improve constipation, but not actually cause too much urinary frequency. So how do you approach that, Dr. Hadi? Dr. Thacker said that you had all the answers. That's what he told me.
That's why he's missing from here.
Yeah. This is why I'm actually the moderator, so I don't have to answer these questions. I just pose them.
Basically, you guys have covered it very nicely, but I'll add to that a little bit. One thing we have to also look at, look at every time you come in, bring your list of medications. I mean, that's very important because sometimes you're taking diuretics at night. I mean, that's really a killer in this situation. So we have to look at a person, like I said, as a whole and look at what else can we do. Are you getting off at night? Meaning, you're not, your medications are wearing off, so you can't make it to the bathroom on time. That'll increase the risk of falls and stuff. So from a bladder point of view, I think you guys have covered it nicely, but this is another aspect that sometimes gets neglected at night, is to address the other aspects. How do we minimize your, is it medication that is contributing, or not going to the bathroom and then leading to a fall and stuff because the Parkinson's medicines have worn off. And then having something close to the bed at night, especially if that's an issue, from a lifestyle kind of change that you can make.
I think that it's almost always best to try to look at more conservative approaches before we start thinking about more advanced approaches. It's always attractive to think about the advanced approaches, but sometimes the answer is actually a little bit simpler. So what about physical therapy type approaches to help improve bladder control? What about Kegel exercises, for example? I'm going to pose that to the therapist. They're debating who's going to answer this one.
Exercising the pelvic floor is really important. The Kegels are good sometimes, but you have to be really careful to not over contract the muscles. So I know that's difficult. So if you are having issues, going to a physical therapist that specializes in pelvic floor would actually be very beneficial to have those things addressed.
Okay. Yes, Dr. Egli?
Yeah, this is, we have this idea that if we go to bed, we fall asleep, we go down that little rabbit hole, 8 hours later we pop out, nothing happened in between, we had a nice unbroken sleep. That doesn't happen that often as people get older anyway. And the thing to realize is that we actually sleep in cycles roughly around a 90-minute average. And at the top of that cycle, we get into a very light sleep stage. And at that point, we can wake up a couple times a night if we get back to sleep again. We can, without disturbing our restorative sleep. So we can, if we get up, go to the bathroom, and get back to bed and fall asleep, we're not so bad. But we wake up and then we work ourselves up, right? We wake up and then we get all fretful and catastrophize. Oh my God, I'm awake again. Am I going to get back to sleep again? And then that keeps you awake for the next hour and a half, typically. So really, what we need to do is, it's not we can wake up once or twice a night, briefly get back to sleep and be okay. So we may not be able to completely stop having to urinate at night or get up, and people do normally wake up. But what we don't want to do is compound the problem by then getting catastrophic about it, and then we add to the problem and keep ourselves awake worrying about the fact that we're not sleeping. So that's what I would say to that.